morning, everybody, and thank you for joining us. My name is Boris Vilgorin, and I'm with the Managed Care Technical Assistance Center, and I'm happy to welcome you to Making the Connection, conversations around integrated care. I'm also happy for our partners that are joining us today, both with the presentation that you'll hear from our partners and also our state partners who are on the call and our CPI partners as well. So really excited for our really third, I believe, Making the Connection, conversations around integrated health, and really excited to continue our series as we have been doing for the last number of years. So today, what we have structured this as we have structured our previous series around integrated health. We'll do, of course, welcome and introductions. And since we have a number of presenters and individuals who'll probably do the introductions as people introduce themselves and talk their portion of the presentation. I'll spend a little bit about the kind of the purpose and why we do this. It will be then followed by a case summary with a subject matter expert, and then the big portion here, and we're really going to be looking at all of you to participate in our brainstorming session that's going to be facilitated by Rusty Foster and Nancy Covell. And of course, we always have a Q&A and a survey at the end. Just to highlight, this presentation is being recorded, and both the recording and the slides will be made available. And as we moved through other two presentations that we have scheduled, and hopefully you'll be able to join us in April and May as well, those will be also recorded and made available as well. The purpose really here is to discuss integrated health, specifically as it's related to more of mental health, substance abuse, but of course we can talk about behavioral health integration without talking about social determinants of health, touching upon physical health, and so forth. And as you'll see through the presentation and through the discussion, even though our focus tends to be more around mental health and substance use, it goes beyond that, because as we all know, the individuals you serve are not usually don't just have one particular barrier in their life or issue that they're struggling with. So the cases we have had in the past, and this is going to be no different, are pretty complex. They have a lot going on. And again, one of the things we really want from you as we get to that brainstorming part is some thoughts and ideas that maybe haven't been done. One of the difference today we have compared to some of our previous presentations, we actually have a managed care company presenting on the case. We have both Amblem and Carelon have partnered to do this presentation, and I again just wanted to thank them for volunteering and participating here. And so they'll go through that case presentation and provide that subject matter expert as well. But they're also very eager to hear from you in regards to some of your thoughts and ideas. So really excited to do that. Some of the housekeeping, again, as I said, the slides are going to be made available. We are recording. The recording will be available. And we really encourage folks to chat in their comments, their questions, their ideas throughout this presentation. We do also have, I believe, the capability, if you want to raise your hand and speak up. We do have quite a few folks. At the moment, we have over 100 individuals, and we might even have more joining. So sometimes, the raise your hand is a little tricky, but definitely please feel free to chat in throughout the presentation, even as ideas pop into your head or questions or comments and so forth. So really looking forward to a robust, not just presentation, but also discussion. So just again, about the series, as I mentioned, it's about the integrated approach. This series will explore the strategies, as I've mentioned, and approaches provided, and we'll address the highlighted key topics, and we'll share that with you. So I think with that brief overview and kind of approach, I'm going to pass this to our partners at, I believe it's Caroline or Emblem, I'm not sure, who is actually doing the case presentation component. So just let me know when you're ready, and I'm happy to move to the next slide.
Hi, good morning. My name is Tony. I'm the Behavioral Health Case Manager at Carillon Behavioral Health. I'll be the one presenting the member. Okay, so our member is a 56-year-old female. She has Medicaid HARP line of business. The member has a substance use history of alcohol, cocaine, and opioid use. Her substance of choice is alcohol, and she started drinking at the age of 16. She has a mental health history of bipolar, depression, and anxiety, and the member also smokes cigarettes. She has a medical history of anemia, hypertension, GERD, seizures, COPD, asthma, hyperlipidemia, and disease of the thyroid gland. She's had frequent admissions, mostly for alcohol use, seizures, and COPD. She's had over 250 ER inpatient admissions from 2019 to 2023 for either mental health, substance use, or medical. Historically, she hasn't been consistently following up with aftercare referrals for continuity of care. She's not currently connected to any outpatient providers for behavioral health or medical. In psyches, she last picked up behavioral health and medical prescriptions in February of this year. However, there's no prescriber listed, so it's unclear if she was just given these medications while she was in the hospital. She does have a history of MAT. She was getting naltrexone back in 2019, but she's not currently prescribed. This member does not have stable housing. She's from Long Island. She reported living with her uncle in Brentwood on and off. She has also stayed in DSS shelters or with friends, and she was also living in a sober house at one time. She does have a long-term partner. However, he's also an active substance user. Both of her parents and her brother are deceased. So she overall lacks positive sober supports and community involvement. She's not currently employed. She doesn't have any legal issues. She has been approved for Medicaid transportation, so she's able to use that to get to her appointments. And she also gets Social Security benefits. Overall, the member's been very hard to keep engaged. There have been periods when I haven't been able to reach her at all, or her phone is out of service. And when I can reach her, she is often in the middle of something and in a rush to get off the phone. She has had previous case management, health home, HCBS, and peer support segments, but they've been closed in the past due to her lack of engagement. The health home that she was previously connected to, which was Northwell, has attempted to connect with her while she's been hospitalized, but she typically leaves within a day or two of admission. So it was hard for her. It was hard for them to complete that in-person visit. And she's also been brought to our rounds with Emblem for behavioral health and physical health collaboration. So I've been in communication with her assigned medical case manager through Emblem to monitor her hospitalizations and outreach status.
All right, thank you, Tony. Is that just want to make sure, is that the overview of the case before we
Yeah, that's the overview that I have. Thank you.
All right, yep, thank you. All right, so again, as mentioned, and when we come back to the brainstorming session, Nancy put together a little summary to remind us. So as we get to it, some of this information will be on a page so we can refer to as we get there. But before we get to the brainstorming session, and we wanted to move on to that presentation by our expert. And so I just wanted to turn that over to Dr. Sano or Dr. McGuire.
This is Dr. Syme.
Hi. Yeah, hi, good morning. I'm Dr. Rosemary Syme. I'm a medical director with Carillon Behavioral Health. So we're going to talk a little bit about bipolar disorder. And first of all, we need to remember that this is a very prevalent condition. It affects 1% of the world's population. And this is a standard. It's regardless of race, it's regardless of ethnicity, of nationality, or sociodemographic characteristics. And it's prevalent both in men and women more or less at the same level, if not more common in a certain sex. The age of onset is usually around 19 years of age, which means that it strikes people when they're most productive, either because they have plans to go to school, to work, whatever. And also we need to keep in mind that it affects people and associates, and there's a clear association with substance abuse. 60% of cases of people that have been diagnosed with bipolar disorder have comorbid substance abuse, and specifically for alcohol use, it's 48%, 50% of cases. So, you know, these are little pointers that we should think about when working with our SUD population that we have to remember, because many times when we are dedicated to one aspect of care, we forget that, you know, what are the statistical associations? And in people with mental health issues, the vast majority have not only one condition, but several. And also important to bipolar disorder is the presentation that is most common, which is depression. And depression, because people are depressed, you know, we as healthcare providers, all of us, sometimes get focused on that aspect of care instead of thinking, well, bipolar disorder, also the most common presentation is depression. And this is what leads to the fact that people, by the time they get the correct diagnosis of bipolar disorder, 10 years usually more or less have occurred. And so this person has been treated only for depression during that time. So I think these are little pointers that we should keep in mind. Also keep in mind that if people all of a sudden, you know, get presentations of bipolar disorder and they're manic and whatnot, and they don't have a history, they don't have any factors that you could think that, you know, predispose them to having this type of illness, well, could this be a medical condition that is looking a lot like mania? There are several medical conditions that also look like this. And now I'm going to leave it up to Dr. McGuire from EMBLEM. Thank you.
Thank you. So hi, I'm Dr. Kelly McGuire. I too am a medical director. I am on the EMBLEM Health side of the fence. So just a little bit of a background for you all that don't know. The relationship between EMBLEM Health and Carelon. EMBLEM Health, we are the insurance plan that covers all of physical health and behavioral health needs. And our vendor for the behavioral health services is Carelon. So I am a psychiatrist. But I am employed on the EMBLEM Health side of it to be overseeing our behavioral health vendor. I am standing in for one of our physical health medical directors, Dr. Folan, who is in a boards review course right now and was not able to attend. But I'm going to play the role of the physical health medical director, who would typically be the one working with the physical health case managers and liaisoning, as Dr. Syme does, with the behavioral health case managers and coordinating integrated care for these members. So some of the things that we want to pick out as pertinent in this member's medical history, there's a few things there, but the ones particularly notable that we need to make sure to stabilize because they can present as or worsen or exacerbate, you know, these psychiatric symptoms are that we know if, you know, this bipolar, if our mood, if we're not taking good care of ourselves, then we're not going to be taking good care of and on top of our regimens for seizures. I'm not quite sure what this individual's thyroid disorder was, high or low, but either way, we know this person has highs and lows. And so either way could be presenting as you know, this member's psychiatric systems as also well as disorders of the blood. And so we need them to be their healthiest, you know, version of themselves, you know, mentally, and to be able to take care of these physical symptoms. And these physical symptoms, you know, problems being out of whack are definitely going to not only cause their own problems, but definitely worsen our psychiatric problems. So you can see how they are intertwined. And just as Tony said, you know, one of the things that she's doing is getting updates on the medical admissions, because sometimes the admissions are for medical reasons, but our treatment plan has has, you know, the whole vision on board. And so we need to know every time there's that point of contact, as much as we don't like to see it when our members get hospitalized. When they do, that's an opportunity for us to be contacting, outreaching, coordinating care, and getting all our treatment planning done there. So point of the matter, we really can't separate our physical and our behavioral symptoms, and these are some of the ones in particular that are being targeted here that could particularly exacerbate this problem.
Excellent, thank you.
That's it
Just
for us. Thank you.
Wanted to ask us if there's anything else you guys wanted to contribute in regards to this. Also, if folks had any questions before we move on to the brainstorming in regards to just general discussion about how physical health and mental health, substance abuse interact with each other, as was just mentioned, and also discussion around bipolar disorders in general. I don't know if folks had any particular questions before we move on to our next segment, where we're really going to be looking for audience participation, as they say. So let me just check, make sure there's nothing coming through the chat or. All right, well, we have plenty of time. If something comes up during the discussion, I think that please feel free to raise. And I think with that, we're going to turn to brainstorming. And Nancy and Rusty, do you want us to, I guess, stop sharing and you're going to share your screen with some of
Yes.
the information? All right.
Well, good morning, everyone. I'm Rusty Foster. I'm from the Center for Practice Innovations. I work in the Focus on Integrated Treatment initiative, and which is really concerned about integrating mental health, substance use, and physical health in one kind of treatment. Because we know these all interact, and if you treat them separately, the outcomes are not very good. And so that, and we've been doing that with OMH and OASIS providers throughout the state of New York. I'm really happy to be here. We always have a very exciting time doing the brainstorm. And I just have a couple, and you could see we have the kind of little thumbnail sketch of this person, and then on the left side with the goals, but we also have the goals on the right side, and we want to keep those in mind when we're doing the brainstorm. And what we're going to do is we're going to and I know that people have been in probably brainstorms. It's a model of really getting ideas out. But just to reiterate about a brainstorm, one is we don't go back and talk about a particular idea, because then it really halts the brainstorm. So we want to get as many ideas out as we can, and we want to be, there's no odd thing to come up with. There's no odd idea. The more ideas we get, and sometimes it's the ideas that you say, boy, that's really weird, that really maybe is the one that's going to work. So we want to pick your brain. We know we have lots of people on. We have 100, I see it's 138 people, and from throughout the state. And you guys are people that work in the field. You have a lot of experience. You have a lot of education around this. So we want to really pick your brain. And at the end, people from Emblem and Carillon will select 2 or 3 things from the list, and it's usually a long list, from the list that they think maybe that really would be helpful, and they're going to try those ideas out. So, so are you ready? You guys ready? You just look at the goals and what you think would help with achieving those goals.
So Rusty, if I can jump in
Yeah.
quickly, because I hope most of the folks are on Zoom. Some might be on their phone and so forth. Maybe, do you want me to quickly run down, remind folks again the case and some of the goals before we jump in, or?
Okay, yeah, no problem. And
Yeah.
by the way, I'm glad, Boris, you said that, because you could use your chat box or your audio to give ideas, and we're gonna make, Nancy's gonna we getting some ideas already.
That's
So
good, that's good. So
you could
while we get the ideas, let me quickly run down, and then maybe Rusty, you can go and talk through some of those. So again, it's a 56-year-old female enrolled in Medicaid HARP, with alcohol, cocaine, opioid use, bipolar, depression, anxiety, anemia, hypertension, GERD, seizure, COPD, asthma, hyperlipidemia, and thyroid disease. Hopefully that was close enough. It 249 emergency room and inpatient admissions, I think in the past, it sounded like 4 or 5 years, or something like that. Combination of mental health, substance use, and medical treatment. Health home enrollment is intermittent. MCO peer specialist also intermittent. Managed care, behavioral, and medical case manager, unstable housing, currently living in women's sober living facility. Medicaid transportation is set up, occasionally stays with an uncle or friends, and overall lacks social supports and community connections. The goals, some of the goals that was identified by Caroline Emblem are engagement and care, specifically to agree to meet with providers, including peers and care managers, connecting with social supports, such as social terms health, to get in the way, reduction of course in ER and inpatient services, and anything else creative you can think of, as was mentioned by Rusty. And of course, we're gonna identify those 3 things. I know I went really
Okay.
fast.
Boris,
was-
we need to go back to the brainstorm, or
Go
else
for it.
we're gonna lose these.
Yep,
All right, so we have from Denise, we have attending peer support groups and develop community. Okay, building trust first. Okay, so then we have okay, identify secondary gains for high ER usage and help her find more appropriate sources to meet those needs when appropriate. Okay, thank you. And that was, we heard from Hazel, we heard from Denise, we heard from Tylea. I don't know, I'm not a great pronouncer, so I apologize if I don't get your name right. And from Deborah Hamilton, we have ask her what she wants to do. What are her goals? Does she want stable housing? Does she want to be more engaged? Utilize motivational interviewing if she will meet with the counselor. And that was from Deborah. And then Carolyn says a supported housing program that deals with dual diagnosis. Denise says medical and behavioral treatment team collaborating for better outcomes. Nadine, this client is a clear candidate for AOT. That's assisted outpatient treatment, but that's where you get mandated to treatment. Will lead to close monitoring by care coordination and facilitate psychiatric admissions that are needed to stabilize. These are great. They're coming in fast and furious. Elizabeth says, thank you, everyone. Elizabeth said referral to core program. And here's one time, and we might want to stop here 1 minute. Elizabeth, could you tell people what core stands for? You could unmute if you can. Well, we're going to go on till we hear back from Elizabeth. David says, since main substance abuse, among others, is alcohol, AA meetings might be a good option among others. Ziamara said, housing food security, pros or core. Oh, it's like, must be an
We're
old.
familiar with CORE. Someone put what it stands for in the notes for you, but yeah.
Oh, it's in the chat box?
Yeah,
Yeah, community-oriented recovery and empowerment.
Okay.
Good job on whoever.
Is
We
that,
all
it must
know
be an
about the
old,
services, but what the
yeah,
acronym stands
must
for is
be,
a little trickier.
okay, thank you. And Ziamara also mentioned cores. It says housing pro security also pros or core services to have community connections. Introduce a peer specialist at the very first visit and continue to check in and build rapport. That came from Matt. From Gustava, Housing First, which is I actually like Housing First, but I don't know if that will work with this person. By the way, this person is a very complex person, has lots of different needs. But we can't go into that in terms of, we should consider that when we come up with our brainstorming ideas. But when we go back to hear from Carolyn and Emblem, we could hear more through them when they decide what ones they might want to try. Care coordinator through a health home. That was Christopher. Charlene said, what is the current location of residents? That's a question. Tara said, talk to her about the goals we have and see what her goals are. Hazel said, NA and AA support. I guess those are meetings, opportunities to explore passion or interest in the community, and it's listed as a question mark. So that is, it must be explore with her or her passion or interest. And that was from Sasha. Anne said, finding a peer who could not just make that personal connection, but can help her identify what her goals are and how she can best achieve them. So looking at her goals, having the peer specialist review her goals. And then that was from Em. Pearl said peer support. Talia said set up a multi-provider consent, if she agrees, that allows her providers to have real-time communication when she shows up to ERs to allow for rapid coordination of care, shortens ER stay. Okay, that was from Tylea. Dwayne May said, consideration of adverse metabolic effects of psychotropics on physical conditions. When was she first diagnosed? Clarifying question. Okay, so ask that question. Identify the barrier. That was from Charlene. Euphemia said, identify the barriers to engagement in programs and treatment experienced. I'm assuming that what gets in the way of her accessing programs. Elizabeth said, community-oriented recovery and empowerment. So that's core. And referring her to that. Home visits and build a relationship, do home visits and build a relationship with known family members that Lori stays with. Jennifer said community-oriented recovery and empowerment services. Another idea of referring to and Ziamara. So there's a lot of people recommending referral to the community-oriented recovery and empowerment program. Other people also are recommending referral to PROS programs. Yolanda said it's an array of services CPST, community therapy, peer support, skill building. So getting her involved in a program that has an array of different types of services that she could access through one program. Tylea said, find out from her, what does she feel is her reason for and gaining more stability? This may help give insight into what she sees her needs are. So figuring out how to work with her on identifying her needs. Euphemia says, once the barriers are identified, meet her where she is at and ask her how she wants to prioritize them and proceed forward. Hazel said, get her a care team and a case manager. Okay, did we run out there, Nancy?
I think for now,
Yep.
you
Yeah,
have,
yeah.
yes, for now you have, yes.
All right, well, that is.
You can
I'm
take a
out-
breath, Russ. Take
I
a
know, I'm
breath.
out, I was just gonna say, I'm out of breath.
Yeah.
This is a great group. You had a lot of ideas and you identified a number of programs that potentially could help this person in with her needs. It's complex. I think, just from my perspective, it's like, there's a couple issues that I saw. It's like, and I don't know if, well, how do you give her how do you get her involved in stable housing? And somebody said housing first. I don't know if that would work, but that's an issue. But also, how do you provide, you have to provide services for all three kind of areas in an integrated fashion? Where's the best place to do that? So you can't just do mental health and have her drinking a lot of alcohol. You have to do both mental health and substance abuse, but you can't forget the impact that medical has. And I guess maybe I could throw this out, and if someone from Carillon or Emblem would jump in on this, that would be great. But how would you engage her? What would you do to engage her in services? I mean, people
Russ,
mention what?
sorry, can I interrupt? Because we have somebody, so I don't know, Carrie, if you still want to unmute yourself. I know you had your hand up.
Oh, I missed that.
But-
Okay,
but
yeah, and you have
also,
the
They
act.
mentioned ACT, so I don't know, I just want to get,
Harry, do you want to mention that? Talk about that?
hopefully they can unmute themselves.
Or did you want to add, this is the assertive community treatment?
Yep.
So sorry, didn't
I'll get
mean
them
to
in.
raise
Okay,
my
yeah.
hand.
All
Okay.
good, but thank you for the recommendation of ACT.
Yeah. So assertive community treatment is another program that is out there and possibly could be very helpful for this person. Charlene, is there a way for communication? This was a question. So I'm going to take the question mark off and to find a way for communication among the different options, the different treatment options, I'm assuming. And so if she's seeing somebody for mental health and maybe substance use together, but not for medical, finding a way for all those options to communicate. Tylea said, I don't know about others, but I don't have an option to unmute.
Yeah.
I don't have anything to say, just giving you that heads up.
Great,
So some
thank
people
you.
some people might have trouble using the audio. Does anybody have, I just want to throw this out because I think this is a goal that would that was listed. How would you engage this person? Because I think this person gets involved and then gets gets disengaged somehow for some reason. So is there anything that somebody would recommend that helps people engage in the treatment that the provider is providing?
And Carolyn, would you like to take that one? Tony is the
Yeah,
case
so,
manager,
you
Dr.
know,
Stein.
Yes. So, the first thing that I would do is to look at it from a perspective of patient-centered care. Because
Ah.
what may be important for any one of us is not necessarily important for the member or patient, right? So we have to look at that and then facilitate having a relationship through that. And I would think that's the first thing that needs to be identified. For women specifically, you could help to motivate them by looking at the possibility of safety, right? We all want to be safe, regardless of, what's going on in our lives. It is safer to live in some type of supervised facility than it is to live on the streets, which I presume this lady does at certain times because she doesn't have a clear place to live. So that may be a way to foster communication and a relationship. However, I concur with everyone that these are all things to be tried. I think that the peers and the peer programs are excellent for trying to establish a relationship of equals, right? Because many times it turns into this control situation with certain clients. So
and
that's what I
Dr.
would say as a starting point.
Yeah, great. That's a great idea. It's a great contribution to this list. And we did have more coming in when Nancy said peer advocates, which you were talking about. Like someone said, meeting them where they're at. That was
And
from
just
Terry.
to be clear, this member does have this individual does have a peer, and Carolyn does have peers
All right.
that they.
Listen, when we do, thank you for that, but we just want to throw these out and then you
sorry.
get to pick. So if you have a peer, you're not going to pick that one. So, but we just want to let people feel, open to saying whatever they want to say, if that's okay. Meet people where they're at. Relationship building when providers mirror their community. Peer advocates are crucial components. You must build trust. Without trust, she won't engage. So building trust. And that was from Denise. And Anne Marie said exactly. Brenton said outreach, meet her basic needs, housing first, stable housing will allow other supports to fall into place. Peer advocates, there's a lot of, and it's it was what you were saying, but because you do have a peer working with the person, but peer advocates are very, very important. They can also offer a warm handoff when she's coming out of the ER. Peer advocates can also offer a warm handoff. Okay, that was from Charlene. Euphemia said, ask her if she is comfortable with her therapist providers. If not, let her know that she can change them. Tylea said, yes, as the speaker is saying, you may have to identify what are her motivations to stay connected. She has to feel like she is getting something out of it, either by her own personal motivation or external motivation. I.e., if she has a desire to be compliant with mandates. Okay, that was from Tylea. Denise said, peers with lived experience are relatable. Maybe she doesn't feel comfortable with that peer. Ask her. Tylea said, has there been a multi-provider case conference? Host these ongoing until things are stabilized, weekly, bi-weekly, etc. Dwayne said, okay. Pearl said, it is not so easy to find the peer advocates. This is a great resource, but difficult to find. Unfortunately, she needs ongoing support. That's from Pearl. Carva said, explore with her why she wants to avoid reality by using substances of abuse. Find out what her goals are in life. Has she gone to Phelps yet? Does she have a SPA application in the works? I'm assuming that's for housing. I work for mobile substance use disorder federations. My manager is Colleen Jeffress, and there's a phone number. Our office is in Copeg, no billing grant funded. SAMHSA doesn't interfere with other services. So this is just an idea to use this particular service. So there's a number there if you wanted to do that. Ask her what anxiety she feels about sobriety and housing. She has a lot going on, and it can be overwhelming. This is from Euphemia. The other one was from Deb Wolfsong about asking her about her anxiety. Euphemia says she has a lot going on and it can be overwhelming. If she is overwhelmed, discuss together ways it can be made more manageable for her. Okay. Woo. That is a very, very inclusive list, and it really also talks about lots of options in terms of programs, ACT, PROS, CORE, and in terms of peer advocates, peer supports was something that people find really support. It sounds like she does have a peer that's involved with her. There's a lot around making sure communication happens among multi-providers. If there's somebody that's doing mental health, somebody's doing substance use, somebody's doing physical health, how do those collaborate together and develop an integrated plan with the person? Other,
Rusty? Yeah,
yes,
Rusty, one of
yes.
the things that I know we had a goal on top that I'm not sure, maybe we can explore more, is around that social connection,
Social supports,
social support. I know there was a mention that she, I think, sometimes stays with her uncle,
yes,
friends.
yeah, she has,
So-
yeah, mentioned, right, you're right.
Right, so I'm just curious if folks have any thoughts around, but again, it seems like everything is almost intermediate, right? There's the peer specialist is not always in the picture, right? Meaning that she disconnects with the peer specialist as well as with the care manager, as well as with treatment, but also it feels like the uncle and friends, she's occasionally stays with them, right?
Yeah.
It's not also like, so I don't know how strong that relationship is and connection, because we also know the family, friends, community support can facilitate that engagement and support overall. So I don't know if folks had any thoughts or ideas around that, and how could that be more explored? So I don't know, Rusty, if you had any thoughts as well.
Well, I want to put what you just said as one of the ideas in the brainstorm, which is explore her social support system. Is that one? But then we could add, what would you all recommend for building her social support system? Because that is very important, and especially family, but friends could help her connect with services, could help give her people need friends and supports out there. So what is there?
Yeah,
well,
can I just say a couple of things? Excuse me. Can I just say a couple of things about what you're talking about, the support?
Well, could we just go through, is this, who's talking? Is this Dr. Sim?
Yeah, Dr. Syme, yes.
Dr. Sim, could you hold for 1 minute and we'll just get
Okay,
through
sure.
the list and then you could add that piece. So, Jamie said, is there local support groups or interest groups that she would like to attend? Deb Woolsong said, are her social supports sobriety supportive? So I'll just make that not a question, but say, because Deb, you could correct me if I'm wrong on this. It's more like ensure that her social supports also support her sobriety. So you don't want her supports being people who drink or do other types of drugs. So is that all right, Deb, to do that? To just change that from a question to a statement? Okay, sure. Okay, thank you. Ask her for her consent for her uncle or any family friends member to be part of the treatment team reviews. Focus on her strengths. So those are two different ideas. One is get her family friends involved in the treatment plan meetings, and also focus on her strengths. What are her strengths? Caroline said, nature supports is a great way to engage in treatment as a collateral input. Nature supports.
Natural. That's true.
Supposed to be natural?
Yeah, natural.
Well, I'm thinking,
I
oh, yeah,
love nature too, though.
take her
Of course.
camping.
Exactly.
Which also might be helpful, but okay, natural supports is a great way to engage in treatment as a collateral input. Natural support, whether family or friends, can be part of her life when paid professionals are not there. So build her natural support systems, okay, and connect her with her natural support system. That came from Caroline. Carrie said, it seems like she lacks connections and commitments, so just having one peer to engage her would be best to start versus more social supports. Okay, that's from Carrie. And now, Dr. Sim, I'm sorry, I cut you off. I just saw more things coming in on the brainstorm. But what did you want to add again?
Yeah, just briefly that, I think they said it all, actually. These are a number of incredible ideas. But it's important to make sure that the social supports that they do have are sober supports, right? And are going to be supportive in her goal, if indeed that is her goal.
Yeah.
And what I would like to say is that her periods of isolation are probably correlated to the periods of drug use, right? Because this is what we see with the behaviors with the rest of the population. So, and the fact that she comes out of these periods and then she doesn't have sober supports, right? So that may be a way. This is something to be aware of, and it's also a way to perhaps engage her.
Right. So when she's using, she becomes more isolated. And then when she stops using, she doesn't have non-using supports out there for her. Did I get that right?
Yes, that's part of and I'm not saying specifically with this patient, but it is part of the behavior.
Oh,
that we
okay.
see
I see.
yeah.
Okay.
So I know we have more other things to discuss, but I really like this, that she's currently in a women's sober living facility. That's a safe place for her to be. That in and of itself is a little bit of a consistency and community. In my
Is that the
first thing
sober housing? That's the sober.
yeah, she's in women's all women facility.
Yeah.
So things that we're talking about, like her safety on the streets, her having, consistently, being able to have, more meals in a bed. And next, I'd like her to have a consistent primary care provider, you know,
Okay.
she's
Yeah,
getting meds piecemeal here and there, just when she gets discharged from a hospital or an ER and she has some pills. She's not consistently getting them from anyone. I know, yes, I would like her to have a home, but I also want her to have a medical home. And I know she wants that to be close to her physical home. And
Yeah.
thus, you know, we're, you know,
Yeah,
right now in limbo, but yeah,
Right,
consistency.
could we
need
open that up
consistency.
to see what, because the issue, she does live in a sober housing and it's women only,
Mhm.
but she sometimes is on the street, and so there's a safety issue. You worry about her safety. Is there any ideas in what, you know, because she leaves the sober, let me just ask a question quickly. Does she leave the sober housing when she starts using
Yeah,
Is-
so unfortunately, sorry, this is Tony.
Yeah.
I'm not sure if she is still currently in the sober facility,
Okay.
because she does, you know, like you said, often leave when she is using. Um,
Okay.
and
So
there are
so
periods
there's
of street
how
homelessness.
what would people recommend to make sure she stays safe? And I'm sure that everybody has worked around this particular issue because, you know, we often worry about people who are using and being safe, and so and somebody puts Carrie put well, I read Carrie's, and Marie put, what is it that she wants? What are her priorities? And if we could, I like to change these from questions to more statements, because then they're actionable. So, Anne-Marie, you could tell me if this is okay, but what if we said, ask her what she wants, ask her what her priorities are? Is that all right? Okay. Ann said yes. Thank you, Ann. I don't know what I would do if you said no. Charlene said, can someone answer my question? When was she diagnosed? Well, we're not going to, Charlene, we're not going to be able to answer it during the brainstorm, but maybe after the brainstorm, somebody from Emblem or Carolyn could just say, you know, you're curious about when she was diagnosed, what her age was, I'm assuming.
Yeah, there's a lot of diagnoses, and so I'm sure it's you know, interesting to know which came first, you know, and the timeline of the presentation of these can tell a lot.
Yeah. There's some point where you could think about what came first, but that doesn't necessarily help. It's more like, how do these interact at this point? Seeing they're all there, how do they interact, and how what would help? You know, and you have to work with all of them. If she's using substances, that's going to impact on her mental health and her physical health. If she has physical health problems, that's going to impact, right? So they impact on each other. So how could you develop an integrated plan? And that's why this is called integrated care. So this is an important part of the process. Charlene, could you, oh, I see. Okay. So that question, okay. She was failed by our system. So could you, Charlene, what would you want to do? What would be something that would be an actionable idea? If she was failed by the system, what would she find, what would be helpful at this point? I mean, you don't have to do it right now, but, okay. And we have identify her goals, interests, and values. Values. What does she value? Meet her where she's at. I think Dr. And I know I'm mispronouncing your name, Dr.
Fine.
Syme? Dr. Syme mentioned
Yes.
patient-centered care, doing person-centered care, that it's not what we want, it's not what we think she should do, but where is she at? What does she want to do? And people are saying this, you know,
It's a very important theme. I like.
and now Dee Brown said use of motivational interviewing, person-centered care, map her diagnosis. I missed this one. Map her diagnosis on a timeline to see how mental health, substance use, and physical health overlap and interact. That's a great thing. That we often, you know, in trainings, we often teach people the timeline, do a timeline, okay, and how they are connected and how they influence each other. And Charlene said, figure out a way to address earlier needs so that she is not a 56-year-old and a case study. Some of these interventions would have been more beneficial at earlier onset. She was struggling for a long time. Evidence shows early interventions are the most effective. That was from Charlene. Elizabeth said, help her do some value exploration so you can connect her goals directly with what is important to her. Review harm reduction strategies. So we have two things. One is really look at what she values, help her identify what's important to her, and connect what she wants to do with what her values are. And then the second one is look at harm reduction strategy. Don't think about, I'll just leave it at that. So review harm reduction. And somebody said, I miss Dee Brown, use motivational interviewing when working with her. Dee Brown is back and said, develop a shared care plan and a team-based approach to provide her with a team of practitioners instead of a referral-based approach to engage her more actively. So have a team work with her versus having individual providers, a collaborative team.
Yeah, Rusty, if I can jump in here in regards to the timeline and exploring what the individual wants. And I know in previous presentations we've done, one of the things that was mentioned is in the timeline exploration is to explore periods when maybe the person was more engaged, right? I mean, this is 56-year-old, like was mentioned, you know, to look at were there periods in this individual's life where they were maybe sober for longer periods of life, more engaged, more involved. Maybe that was 20 years ago. And I know in other presentations, one of the suggestions was to explore what was happening during that period that motivated that person to be more sober, more engaged, more involved compared to what's happening now. And revisit that with the individual saying, I'm making this up, of course, 20 years ago, you were doing well for 2 years, right? You were, engaged in treatment, you had housing, and kind of explore what was different than now. So just kind of bringing some of the idea from previous. So it's in line with exploring what the person needs, but also looking back at a timeline to see what was there that motivated this person to be, more involved in their own treatment.
Yeah, that's great. That's great.
That's
And that gets to be person-centered because it begins developing a person's strengths, looking at what they were able to do. So that's great.
And Hazel, thank you for summarizing my
good nutshell.
long paragraph with what worked for you in the past, because that's really what I was saying. So thank you, Hazel.
But there is, I have to say, there is a tool called the timeline. Ken Minkoff, who does lots of work around integrated care, has done it for years. And in the work he does, a timeline is an important tool to work with a person, to explore with a person. Let's put that. So, and that's the one question. Ask her what worked for her in the past. What worked for her when she had a successful time? Did she ever work? You know, did she have a period where she wasn't using drugs and alcohol? That kind of stuff. Anybody else? Let's see it's 11. Anybody else wanna, I mean, we have
Quite a few.
we have a long list and Nancy, you're doing it. I don't know how you do it, but Nancy's keeping up with this. And she's made a summary of frequent recommendations. Oh my God. So here's the frequent ones. The ones that were offered more often, peer provider support, make sure she's comfortable with providers and allow her to choose providers where not. So she gets giving her some choices in life, identify support or interest groups for her to attend, build natural supports, connect with other services, offer housing first, integrate medical. You made this a little bit easier for Emblem and Carolyn, I believe, in picking things out. But there might be something not on this list that they like. Integrate medical and behavioral health, meet her where she's at, identify her goals, interests, and values. Okay. Here's more. My apologies, I have to leave. You all are in good hands with Caroline. Oh, that's nice. That's Kelly McGuire. Okay, Dr. McGuire. Okay, bye. Thank you for being here. Hazel said, ask her the miracle question. Hazel, do you want to tell everybody? I mean, maybe everybody knows this, but what is the miracle question? What would you ask? And Lynn said, off the beaten path, but how about spiritual practice or meditation? That's an interesting idea. That was from Lynn.
Yep. Yeah, I would say, yeah, no, that was very helpful. Thank you, Lynn. But exploring, right, spirituality and other types, with the individual. Yep.
Yeah.
Yeah, that's
Or
great.
helping her, teaching her meditation.
Yeah.
I mean, she might not be interested in it, but meditation is a very, it's very helpful for lots of different things. So, Hazel, do you want to tell us what the miracle question is? Do you have audio?
Well, we might be able to unmute, but I don't know if Hazel.
Well,
wants to.
let's ask Hazel what she.
Yeah.
Do you want me to do it, Hazel? You could say yes or no. Yes, okay. So the miracle question is, if all your problems went away, if you were feeling great and tomorrow you woke up and everything was perfect for you, what would that be like? Okay, so that's the miracle question. You don't actually say if a miracle happened because you don't want a person feeling they need a miracle. But, if everything was perfect for you when you woke up tomorrow, what would that be like for you? And the things that they tell you are the things that are important to them. Okay, and it's always helpful to work with somebody around their strengths and what's really important, what they value, and what their goals are. So, thank you for raising the miracle question. Anything else?
Yeah. And if not, we can also pivot to explore with our Caroline
Okay.
nurse.
So
next
you mean to
phase.
go through the list to see
Yeah.
what they like?
Yeah.
Okay. And Tony, I know you are the care manager. And so you're saying there is a peer specialist that works with this person?
Yeah, so we do have peers on staff. She has been connected to 2 different peers at one point, but still just lacking that engagement. So she just kind of disconnects from the peer.
Yeah. And these are people with lived experience.
Correct. Hmm.
Yeah, yeah, yeah. And they connect with her for a while and then she disconnects.
Yeah, so unfortunately, I mean, we really only have a telephonic reach with our members. So I think that can be a barrier because, if she doesn't pay for her phone, then there's no way for us to connect with her. So I think more like in-person approaches would be really beneficial. And I know people had recommended like Actor AOT. And I was also even curious about someone had mentioned the Federation's mobile SUD.
Right.
And that's one of the reasons why I had referred her to a health home before, because I know
Okay, I
that they
see.
can conduct those in-person visits.
So her services mostly, I mean, her medical services, of course, like are not, but most of her services provided by Carolyn and Emblem are telephonic.
So just the case management and peer support option.
Oh, I
She can get, mental health, substance use services in person
Okay,
with an agency.
okay. And we do have a long, we have a long, this is from Kara and CK Post. This is from their website. The core component, this is a treatment provider. The core component of the women's track is the multidisciplinary. I might not want to read all this, but people from Caroline and Emblem could look at this because this would be, I'm assuming, a referral kind of to a treatment provider. But Kara also said, I know in the past, clients that are frequent flyers, clients that use lots of services are placed on limited places where they can attend treatment. I had to jump through hoops to get one of my clients to get to Samaritan Village because he was restricted, Southampton Hospital, due to being a frequent flyer. So sometimes it's hard to get, I think on the second part, Kara, I think this is what you meant. It's hard to get people who are in, who are in and out of services. They leave services. It's hard to get the programs to take people who often disengage. So it's like, I don't know if this is it, Kara, but are you saying refer her to a program that will allow people to come in and out? It's like a drop-in. Okay, Denise said in person is a better approach versus telephonic, I'm assuming. The peer should be in the individual's age range, ideally. Peer in-person services as well. Kara said, Medicaid restricts them after so many visits. Is she restricted?
Yeah, there is such a thing that happens sometimes to this individual. I don't think this particular individual, because sometimes they'll lose their managed care.
Okay.
But that's something just to look at because that could create a barrier. So that's just like a Medicaid eligibility issue that's been raised. But
Yeah,
sometimes
but this is not happening with this person.
it doesn't look like it.
No, she doesn't have any restrictions.
Okay,
Yeah.
okay.
Tony, I'm just curious. I know a number of folks at CORE. Have you explored CORE before? Is that because that's more in the field rather come to the program services?
Yeah, so in the past, a couple of years ago, when she was, really well connected with the health home, she was getting home and community-based services, and she was meeting with a peer in the community through that program.
Okay, so now there's CORE as an option.
Right.
So I
Mhm.
think that's what folks are recommending that as well. So,
Right.
yeah.
Yeah, I think that would also be a good idea to have that,
Yeah.
in person.
Yeah. Not to take away from pros, but pros is still more of like you come to the program where CORE
Right,
more
right,
in the
which would be
field.
harder for her.
Yeah.
Yeah, yeah. Yeah, so, huh, it's kind of this is a real thing about meeting where she's at.
Yeah, exactly.
Meeting her where where she's residing or if she's on the street. Is she somebody that is homeless periodically?
Yeah, so I can't remember exactly when, but sometime last year, she was living in an apartment with her partner at the time. She was
Wow, she had a
paying the
partner.
rent with her Social Security benefits, and he was working. But because of his substance use, he had lost his job, so they weren't able to pay for the apartment. So she's been kind of homeless since then, living on the streets, staying with her uncle or friends.
But she had a partner at one point?
She has a longtime partner for years and years and years. They've been
Wow.
together, but he's an active substance user.
Yeah.
Yeah.
Yeah, so, right, that's the thing about your social sports being sober.
Yep. So anything else to jumped out at you? I mean, I know it's, and you know, it's a long list. We went through it relatively fast, even though.
Yeah.
Yeah, but,
So should we,
yeah.
Boris, should we turn it over to Emblem and Caroline?
yeah,
and-
Caroline, I think we're yeah, if there's any questions or anything else
Okay.
that we have in the last maybe 5 to 10 minutes that you wanted, and Dr. Syme, I don't know if we covered your point or some, I think you wanted to raise before.
Yes, yes. No, I just wanted to say a couple of things that I think are pertinent to our work with the mentally ill. And it's, for example, in this particular case, it's excellent that he was able to have the necessary skills to have a long-term partner. So even though he is suboptimal, I think we can all agree because he's a substance user, but he does have that added connection and that ability, which is something that other chronically and persistently mentally ill people don't have. So that's an excellent asset. That means that he can form bonds with people. So, so the question there with the behavior of this lady is not whether she can form these bonds. We know she can, but why she loses them. And my guess is substance abuse, right? Or the illness, or both, right? Because if you're psychotic, I mean, I don't know the extent of her presentation because we don't have that information here. But if you're psychotic, you really don't know what is going on or what you are doing in a way. So that is one thing. And the other thing is just to keep in mind that not specifically to this lady, because like I said, I don't know what her more recent mental status is, but sometimes with patients who are chronically ill with mental illness, it can be overwhelming to have all these people asking you questions, you know, rather than worry about being homeless because they're used to that. They become overwhelmed when too many people are talking to them, and it becomes really difficult for them. So I think this is something that we as providers and as agencies need to look at, because I think this drives the motivation behind trying to minimize the number of people and at the same time facilitating that, you know, there are interventions that can be done by a team of integrative health, you know, with physical prescriptions, everything. And ideally, you know, if I had my wish, my miracle, co-located facility. So you would reduce the stigma, you know, the same place you would go see your psychiatrist or your internal medicine person.
Yeah, that's a really good point.
Yeah,
and-
it is. Yeah, and it might not be.
I just want to just say one
ahead,
thing
Rusty.
too. I think the field is moving more and more towards that,
Mhm.
where there's integrated services in one spot. And that was a thing, I've done a lot of work in integrated mental health and substance use. Originally, we're starting to do more with physical health, but we always, this was the definition of integration, right? Services by one team in one place at the same time.
Yeah.
So people who have a lot of, you know, a lot of complexity, if you have it so that they have to go to like over here for this, over here for that, over there, they're not going to be able to do that. They don't do that. At least in
coup-
the literature, it's bad outcomes, but.
Yeah, no, definitely. So a couple of ideas. I don't know if Carolyn, you guys explored this. So one is looking, and again, this is more substance use mental health integration. In one location is a CCBHC clinic. They're fully integrated, one
Oh, yeah.
location, both mental health and substance use. And again, creates its own issues because I don't know how much this person will go to a clinic and so forth, but something to explore. It would be one of those integrated location. And I believe there's also OMH Oasis what's called an iOS license providers. Again, there are clinics that are also more integrated from the licensure
Are you
perspective.
making that as a recommendation?
Correct, yes, under the bullet that Nancy is
Okay.
typing. Yeah, as a couple of places to consider, right? As potential single, if you will, single locations where they might be. Physical health is tricky. They do some of the
Boris,
physical
Boris,
health, but not to the degree that this person needs.
could we have Carolyn pick a couple now?
Yeah,
That'd be all right, because they got a long list to look at.
yeah. I think Tony picked a couple already, right, Tony? If I'm not mistaken, because
This would be Tony and a Dr.
Sign. Yeah,
Yeah.
yeah. So yeah, I
What do
think
you
we already
guys-
have a couple from them.
What do you think would work?
And Tony,
Yeah,
you're the one doing the work, so I'll defer to you.
Yeah, I picked a couple, like you said already, I think that in-person kind of in the field connection with her would be the most helpful, whether that does, extend to ACT AOT or more of the kind of mobile unit, like someone had recommended, the Federation's mobile. And I have, explored the integrated mental health and substance use with her. I think it's just a matter of kind of like, motivating her and getting her there. But I do think that integrated care in one location would be the best for her, so she's not kind of like going all around.
Okay.
Excellent. Thank you.
You got one more choice if you want it.
And of course, Tony and
We could
all of
just
you, you're
stick
gonna
with
get this
two.
list, so don't worry. Like you'll
Yeah,
get this
yeah,
list. We're
yeah.
not gonna hide this from
Yeah.
you, but yes.
Okay, good, because there was a lot of options.
Yeah.
We had about 500 options.
Yeah, definitely.
Well, and and these two are things you're gonna try. So I don't know if maybe you would be able to get back to CTAC. How did they work? Were they helpful? Right? So we don't, sometimes when we have these, the next meeting, we used to have people come back a little bit and say, what happened with, the person from the last meeting? But would you be able to let CTAC know? I'd be curious, like, were these things helpful? Because this is a very complex case.
Yeah, I'd be more than happy to do that.
Okay.
Excellent. Thank you. All right. This was really good. Thank you, Rusty and Nancy, for facilitating this and for all the conversation. Nadesh, can you bring back the slides? I think, in a few minutes we have left. One is to answer the question I think we just got, and again, just to repeat, the presentation, the recording, the slides will be made available. The brainstorming component will be made available as well. Of course, if you have any questions, keep them coming even afterwards if you want to reach out to us. But we'll be sending this out. If not this week, next week, you'll be seeing this. It'll be on our MICTEC website, so you can always access it from there as well. We encourage folks to share it with others. And we also would love to hear from you in regards to how we did. So we have a survey, and I don't know, Nadesh, if there's a link that I think you already included in the chat, but also we have a QR code here. If folks can take a minute to answer a few questions, so this way we can keep improving these presentations. And so while folks are answering the survey, I do want to say thank you to Carolyn for presenting, participating, and sharing their experience. And also, I know Dr. McGuire needed to jump off, so to our colleagues at Emblem as well. And as always, to our CPI partners and our state partners in OMH and OASIS, and to all of you for participating and being part of today's presentation. So look forward to seeing all of you in April and May in our presentations and discussions. And again, thank you everybody for today. So again, thanks and take care.
Yeah, thank you. You guys were terrific.
Thank you.